to prevent to treat malnutrition, but nutrition support is to prevent malnutrition.
Salah, sebenarnya dua-dua pun sama.
Oh,
Sebab before this, people call it nutrition support. Okay, but now they move away from the term support because the nutrition itself considered as a therapy because they have their own calculation, their own dosage, their own possible complication, same like others pharmacological medication.
I see.
Kan pharmacological medication kan ada indication, ada dosage, ada possible complication. So the nutrition also same. So dulu-dulu orang akan panggil nutrition support, but now people tend to call it more on the nutrition therapy.
Alright.
Okay, continue.
Thank you. And previous slide, Fanis. Okay, so we need to know what is malnutrition. Malnutrition is a wasting conditions that resulting from the deficiency in energy, protein, and sometimes vitamin and trace elements. So, what causes this malnutrition in patient? So, some of the causes of malnutrition include reduced food intake, malabsorptions, or altered metabolism. So, what happens if these patients have malnutrition? So, what are the consequences of malnutrition in this patient? Okay, next. So why is it important for us to have adequate nutrition? So first, oh okay.
Nah, apa GI kita pun ada apa GI. Tak, is dia President of Parenteral and Enteral Nutrition Therapy of Malaysia.
Oh okay.
Oh, baru tahu. Ambil slide orang tak tahu siapa. Okay, continue.
All right. Okay. So from his slide, so it mentions that these two categories of people, which are at risk of who may benefit with nutritional therapy, which are the severe malnutrition or patients who are at risk of malnutrition. So who are patients is severe malnutrition. Among of them are who had weight loss more than 10 to 15% within 6 months, BMI less than 18.5 kilogram per meter squared, SGA grade C or NRS more than 3. This one I will explain a little bit later. And serum albumin less than 30 with no evidence of hepatic, renal, and dysfunction. And for who at risk of malnutrition, patients who have eaten little or nothing for more than 5 days, and for patients who are unlikely to eat or eat adequately in the next 5 days, of patients who have gut failure and persistent hypercatabolism. So these kind of patients may benefit with nutritional therapy. Okay, next. Okay, as I mentioned earlier, so after we have know who need who need the support, so we need to know when do we initiate this support to this patient, and what are the criteria. Is this patient safe with if we give this nutritional support, and how do we properly plan the nutritional plan for each patient, and how do we calculate the calorie requirement for each patient, and how to monitor for each patient's nutritional support. Okay, next. Okay, these are some nutrition assessment tools that we can use, and most of us, we usually use this nutrition risk screening. So these are some of the questions that have in the nutrition risk screening. So patient who have more than 3 points in this risk screening are indicated for nutritional therapy. Okay,
So
next.
our hospital use which one?
The nutrition risk screening
Kita
2000.
guna NRS dia ada few tapi tak perlu tahu all. Kita guna NRS ni sebab NRS ni yang paling senang.
Hmm.
NRS ni the easiest. Ada lagi. If you go to hospital mungkin dia orang guna different screening. Tapi if you go the study pun not much different pun. Tak jauh beza. Okay, continue.
Okay, next. Okay, moving on to the route of feedings that will be explained furthermore after this. As I mentioned earlier, there are three route of feeding. First one is oral, second one is enteral, and parenteral nutrition. So I think that's all from me. And now we're proceeding with the enteral nutrition.
Okay, Assalamualaikum. My name is Nabila, so I will continue about the enteral nutrition. Next. Okay, so my patient, Mrs. H, 54 years old, Malay.
Before proceed, kita ada berapa presenter?
6 for this topic.
6. Oh, banyak. Okay, continue.
Okay, so Mrs. H, 54 years old, Malay married lady with underlying sickle adenocarcinoma was admitted to surgery ward due to lethargy for the past 1 week prior to admission. Next. Okay, the lethargy occurred for 1 week before the admissions, and it also associated with reduced effort tolerance, and it becomes worsenings because it disturbed her daily life activities because she was unable to do household chores or cooks. And apart from that, the patient also has loss of appetite for several episodes since 8 months ago. And the patient complained that there was a reduced meal intake from 2 times per day to 1 time per day with reduced portions. Because she was only able to eat from 1 plate of meal to 4 spoon of meal only, and it also become worsening for the past 3 days before the admissions because she was not able to eat any food or drinks. And then there was also loss of weight for 4 kilograms for the past 6 months, from 29 kilos to 25 kilos, which is about 13.48. And then the patient also on stomach diet since 2 months ago. Next. But otherwise, the patient has no nausea, vomiting, or fever. There was also no anemic symptoms such as chest pain, palpitation, or presyncope attacks. Regarding the past medical and surgical history, the patient was diagnosed with sickle adenocarcinoma since 8 months ago, and the right hemicolectomy and double barrel stoma was done 2 months ago. And regarding the food and dry history, the patient currently consumed zinc copper or D. There was no food or dry allergy, and she also did not take any herbal medications. Next. For the family history, she claimed that her mom has kidney disease and hypertension, but otherwise there was no history of malignancy running in the family. For the social history, she is married, housewife, no never smokes, never consumes alcohol, no drug abuse, and not involved in any sexual promiscuity. Next. Okay, upon general examination, the patient is alert, conscious, but she looked like sick because there's all muscle wasting of the interosseous muscles, and also there's prominent cheekbones. But the patient is not in pain or respiratory distress, and the nasogastric tube was intact at the left nostril, and the capillary refill time is also normal, and the pulse rate is 80 beats per minute with regular rhythm and good volume. There was no conjunctival pallor, but the patient is looking dehydrated because she has dry lips and also the tongue is coated. There was no glossitis or angular stomatitis, and there's also no cervical lymphadenopathy. And then the patient weight is 25.8 kilogram and her height is 148 centimeter. Therefore, her BMI is 11.8, which is underweight. And regarding the vital signs, all of them are normal. And then upon inspection of the abdomen, the abdomen is not distended. There was a well-healed midline laparotomy scar that measuring about 13 centimeter. There was also stoma over the right iliac fossa, and the stoma is red in color and protrude, and the stoma is functioning, and the bag is filled with dark greenish liquids. The abdomen is soft and non-tender, and upon percussion is resonant, and the bowel sound can be heard. Okay. Regarding the investigation, the full blood count revealed a low hemoglobins, and the liver function test revealed a high total protein, which may be to dehydrations, and the ALP is also high. The renal profile shows high urea, potassium, and also low GFR, which may indicate acute kidney injury. But however, the sodium and the chloride is low, and the serum phosphate and magnesium are high. So therefore, the
The
patient.
mean is high. Are you surprised?
Sorry, Mister.
The albumin is high. Are you surprised?
Yes.
The
But I
albumin
think it may be to dehydration.
dehydration. Apa dehydration pula?
Hmm.
Okay, so in what situation the albumin is not reliable? Ini kamera ni saya ni tahu, saya off kan. Bukan sebabnya semasa kau nak siasat ni saya baring, ya kepala pening apa semua kan. Saya rambut semua tak bersikat ni, tak nampak handsome. Tak boleh saya kenal. Okay, so in what situation the albumin is not reliable?
When the GFR is low.
Ada tiga situation. First, patient sepsis. In sepsis, the GFR is the albumin is not reliable. Satu. Second, patient ada renal failure. Renal failure, the GFR is not reliable. Third, patient ada liver failure. So in these three conditions, the GFR pula. Ni dah ikut kau lah ni GFR The albumin is not reliable. Okay, so tengok dia punya urea dia. Kan tinggi macam anak tu. Creatinine dia berapa? Okay, tak apa. Urea 35, creatinine
Creatinine is high.
is high. Lah. So patient now ada renal failure. The albumin is not reliable. Tak reliable langsung. Okay. So continue.
Okay, next slide. So the patient is diagnosed with malnutrition with acute kidney injury secondary to dehydration. Okay, next slide.
Diagnosis dia yang dia datang sebab apa dia?
Letter G.
Letter G tak. Apa diagnosis dia? Apa kalau letter kasih diagnosis? Ni confirm Azmi ke Mr. Faisal tak bagi diagnosis ni kan? Ni kau je letak kan?
Dekat pesakit pun letak macam ni.
Ya ke? Malnutrition with acute kidney injury. Circle itu hydration lah. Okay lah. Okay, continue.
Okay. Okay, so next slide. Okay, so in order to decide whether the patient need nutritional support or not, so first we perform the NRS, and therefore the first one is the pre-screenings, which is done to the patients, and it includes 4 questions. So if there is yes to one of these questions, then it must proceed to screenings. So in this case, the answer is yes to the 3 questions, because the BMI of the patient is less than 20.5, and the patient also lose weight in the past 3 months, and also there is reduced food intake in the past week. Therefore, since she has a yes to one of these questions, then it must proceed to the screening. Next. Okay, so for the screening, it involves 2. The first one is the nutritional status, and the second one is the stress metabolisms. For the nutritional status, the patient score is 3, because the BMI of the patient is less than 80.5, and also she has a reduced general conditions because she complained of the lethargy. And then for the stress metabolism, the score is 1, because the patient has an underlying cycle adenocarcinoma. Therefore, the score of this is total, and 3 plus 1, it becomes 4. Therefore, since the score is more than 3, the patient is at the nutritional risk, and so the patient must set up with the care plan for her nutrition. Next slide. Okay, so the nutritional care plan involves 7 components, which is we must calculate the total energy requirement, the carbohydrate, the fat, carbohydrate ratio, protein, nitrogen, and also the fluid that must the patients take. Okay, next slide. Okay, so to calculate the calorie needed for these patients, we must first find the ideal body weight for these patients. And in this case, we must target the calorie to be 25 to 30 calorie of the body weights. And also, since the BMI of the patient is underweight, and we must target the BMI of the patient to be more than 2, than her current BMI. Okay, next slide. Okay, so in order to find the ideal body weights, we must target the BMI of the patient to be more than 2. So the ideal BMI is at 13.8, and then we can find the mass. We can find the mass for these patients, and therefore after we calculate, we get the mass of the patient to be at 30 kilogram, which is suitable for her body weights. And therefore the 30 we multiply with the 25 and also with the 30 calorie. So therefore we get the total energy requirement between 750 to 900 calorie per day. Next. Okay, so for the total carbohydrate requirements, the patient require 2 to 5 gram per day, and then we use the same method to calculate the requirement for the carbohydrates. So we multiply the 30 with 2 and also multiply with 5. So therefore we get the total carbohydrate requirement between 240 and 600 calorie per day. Okay, next slide. Okay, for the total fat requirements, it requires 0.7 to 1.5 gram per kilo per day. So we multiply with the ideal body weight, and we get the answer between 203 and 405
Yang
calorie per day.
senang kira, ambil 1 je. Dah 0.7, 1.5 kita ambil 1 je. Ambil 1 je nak kira senang.
Oh,
So,
okay.
tapi pun ambil in range Okay.
Okay. Okay, next slide. Okay, to calculate the carbohydrate and fat ratio. Okay, first we already have the answer for the carbohydrate requirement, also fat requirements from the previous slides, and then we sum up this calorie and we get the total non-protein calorie to be between 1,005 calorie per day. So the carbohydrate fat ratio is 40 to 27, but the recommended fat ratio is 70 to 30. So in order to find this ratio, we must find the new carbohydrate requirement and also the new fat requirements. We must multiply the carbohydrate with 70% and the fat we must multiply with the 30%, and then we get the answer of the total non-protein calorie to be 1,006 calorie per day. Okay, next slide. Okay, for the total protein requirements, the same calculation is also used, and the requirement for a normal patient is 1.1 to 1.5 gram per kilo per day. So we multiply with the ideal body weight and we get the answer. And also the same one as the nitrogen requirements, which is 1 gram nitrogen equal to 6.25 gram of protein. Okay, next slide. Okay, for the nitrogen and non-protein calorie ratio, it is supposed to be 1 to 150, but in the patients, the ratio is only 1 to 140. Okay, next slide. For the fluid requirements, it is between 25 to 30 ml per kg per day. So in this patient is 750 mils per day. Next. Okay, therefore in this patient, the patient is given the daily diet intake with the oral nutritional supplements. It involves 3, in which the first one is 4 scoops of nutrient optimum with water, and it gives the patient of the total energy of 476 calorie per day. So this give the patient 77% of the total energy requirements. Therefore, this is suitable for the patient because it is more than 75% that must be required for the patients. And then next, the patient is given with 1 bottle of proteins and also 1 hard-boiled egg during breakfast. Apart from that, the patient must also encourage her to eat orally. This is to try to finish the hospital meals, also to eat small and frequent meals, and avoid high sugar food or drinks, and also to take protein from the high biological food such as soybeans or dairy food.
Sebelum start benda-benda ni semua, apa yang perlu buat sepatutnya? Sebelum start untuk kuslah apalah ni semua, apa yang kita kena buat sebenarnya?
Give the
Kena
patient
kita kena menentukan route dahulu. Nak start enteral, parenteral, ataupun enteral dan enteral. Okey. Dietitian punya plan. Ada tak dia kira detail-detail nitrogen apa NPC ratio lah apa semua, ada tak dia kira?
tak ada, only
Why?
yang kalori tu je.
Sebab apa? Sebab pasien ni oral. Oral macam ni kita nak control. seketul ayam. Berapa protein seketul ayam? Kita tengok ayam kampung ke ayam padah. Ambil bahagian chest ke, ambil bahagian pau. Lain protein dia. So kalau untuk enteral, usually people not calculate that detail because too much variable. Terlalu banyak variable apa yang kita bagi. Lepas tu family datang bawa makanan lagi. Lepas tu apa lagi? Saudara mara datang bawa extra makanan lagi. So for us to really calculate is difficult untuk enteral. So yang diorang really calculate for enteral adalah total calorie dengan apa dua tu yang paling penting lah. Okay. Ratio tu susah variable Lepas tu as long as you can achieve 10% of the feeding, that's adequate enough. That's adequate. Kalau lagi dapat baguslah. Kalau dapat 70 plus requirement kan. Ni hanya suplemen je. Dia tak masuk apa yang dia makan lagi. So walaupun dia makan sedikit, tapi kita harap dengan dia makan tu, patient dapat the total calories, dapat more, buat nearer to 100% lah. Okay, so patient ni enteral kan? Betul?
Enteral.
Okay. Okay, continue.
Okay, next slide.
Ada
Okay, so the
kan?
patient is given. Okay, so the patient is given with the enteral nutrition because she has a poor oral intake and because the gut is still functioning with the stomach. Okay, so regarding the enteral nutrition, it is the intake of food via the gastrointestinal tract, and it includes the oral nutritional supplements in which it involves the tube feeding as well as via the nasogastric tube, mesoenteral, also the percutaneous tubes. And the oral nutritional supplement is actually sterile liquids and also semi-solids or powder that can give macro or micro nutrients to the patients. So the routes might involve from nasogastrics or it can also go to the duodenal or jejunals. Okay.
Okay. Tapi the most proximal, the better Most proximal. Continue.
Okay. So the indication for the enteral nutrition is when the gut is functioning, but the patient is unable to eat. That cannot meet the patient nutritional requirements, and also must also avoid parenteral nutrition if there is no contraindications because this is to overcome the gastrointestinal incapacity, and the contraindication is when it is absence of the intestinal function or when there is complete intestinal obstructions, high loss intestinal fistula, increased likelihood of opportunistic infection, or when there is for ethical considerations. Okay, next slide.
Mana severe because intestinal obstruction?
Sorry, Doctor, question again?
Cuba tengok slide di sebelum ni. Okay, complete intestinal obstruction, example severe burns, multiple trauma. Macam mana severe burn dengan multiple trauma boleh cause complete intestinal obstruction?
Because the intestine cannot function.
Itu ileus. So ileus. Ini bukan computer obstruction. Computer obstruction ni mechanical. Ke apa? Nah, mana dia tahu?
Sorry, Doktor.
Yelah, macam ada segi dengan multiple trauma boleh cause intestinal obstruction.
Not sure.
Ayo. Okay, mana ada segi tak, dia boleh cause intestinal obstruction tapi because of diarrhea. Not
Okay.
Okay, continue.
Okay. Okay. So for the types of the oral nutrition supplements, it involves 4 types. The first one is the polymeric preparations, and this type is used in these patients. It contains whole proteins, complex carbohydrates, and also long chain triglycerides. It is also chips and is lactose free and contain no glutens, and it can use for longer period of times. That is, it can use for more than 6 weeks. For the second type is the monomeric and oligomeric. It contains hydrolyzed macronutrients. It also is indicated for patients that suffer digestion and absorption problems, and also when there is pancreatic enzyme insufficiency. Okay, next. The uh, other type is the disease specifics, which exists for example, for the liver disease, renal disease, or diabetes. But this formula is more expensive. And the fourth one is the modular diets that contains macronutrients, in which we can change the amount of each substrates and also the types of nutrients that is needed. Like, okay, the choice of feeding regimes involve 4. The first one is the continuous feedings that provide nutrition by a feeding farm over 24 hours per day. This is usually for the patient that is bedridden. The second one is the cyclic feedings that provide nutrition for about 8 to 16 hours. And then this is usually in patient that is a semi-recumbent positions. The third one is the intermittent feeding, which is used in these patients. It provides nutrition over 20 to 60 minutes every 4 to 6 hours, and it can also be used with or without the feeding pumps. This can be also used at homes, and it's actually more physiological, and also it helps to patient to also eat the other type of foods. And the fourth one is the bolus feedings that provide nutrition over a very short period of time. But however, for this type of feeding regime, it has a very high risk of aspiration to the patient. Okay. Next slide. Okay, so as in the patient, the intermittent feeding method is used. So the advantage is the feeding pump may not be required. It also helps to increase the quality of life because it helps to allow greater mobility between the feedings. Therefore, the patient can also eat other type of food as well. And then it's also more better than the bolus feedings for the patients. However, there is an increased risk of aspirations, and also there can be a gastric distensions or delayed gastric emptyings. Okay, next slide. For the complication, it is divided into gastrointestinal, mechanical, and the metabolics. For the gastrointestinal, the diarrhea is the most common complications. This can be prevented by giving the patient fiber in order to reduce the diarrhea. Apart from that, the patient can also complain of nausea and vomiting, and also constipation, which is uncommon. The second one is the mechanical. This can happen if the tube is mispositioning into the trachea or into the pleura, so it can cause pulmonary aspirations and also cause malposition to the tube and cloggings. Okay, the third one is the metabolic complications because it can cause electrolyte imbalance to the patients and also refeeding syndromes, which will be explained later. Okay. This is our next. Okay, this is our reference.
Okay, Assalamualaikum. My name is Faiz, and I'll be talking about parenteral nutrition for this CPC. Okay, next. So I'll start off with my case of her name is Puan R, an 85-year-old Malay lady with known case of esophageal cancer, presented with progressive dysphagia for 3 weeks duration. Next. So she presented with a 3 weeks duration dysphagia. Initially, she was able to tolerate soft diet, but then couldn't tolerate soft diet, and she's been on liquid diet for the past 3 days prior to admission. She also reported of vomiting of food contents, only food contents, moments after ingestion, with some discomfort around the epigastric region. She also associated with lethargy since she hasn't been eating for some time. So first ever presentation is with dysphagia around December 2022, and she was her history was verified, examined, and later it was found out that she was not fit for chemotherapy. So in the end, esophageal stenting was done instead of a curative therapy. So this is a palliative treatment. So she reported with constitutional symptoms, loss of appetite for 1 week and loss of weight. However, on questioning, they are not unsure of the details. They just reported that her clothes began to become loose. So the relevant negatives that she does not have anemic symptoms, no heartburn, abdominal discomfort, hematemesis.
Okay lah. No, because this is not the seminar of esophageal CA kan. Kita just nak belajar the nutrition kan.
Okay. All right. So next. Okay. She has some risk factors for esophageal cancer, and to note that she has underlying hypertension on single medication, and she defaulted her hypertension follow-up. Otherwise, no significant surgical history or allergies. Next. Okay, so on physical examination, she is alert, not tachypnic, but she appears pale. She has pallor conjunctiva. She is cachexic and speaking in sentences. And she's not jaundiced. Her tongue is not coated. There is no neck swelling. However, as mentioned, she is cachexic. There is some interossei muscle wasting. There's an IV line over the right forearm. No reduced skin turgor. Sorry, not skin turgor. No reduced skin turgor. Capillary refill time less than 2 seconds. No lower limb edema. And per abdomen, soft, non-tender, but it's not further progress since the patient and the guardian denied. And for vital signs, she is hypertensive. I think this is possibly her defaulting a follow-up for hypertension. Otherwise, despite the loss of weight and loss of appetite, her BMI is still within normal range. Next. So investigations, I only put the significant results. For full blood count, she is anemic, iron efficiency anemia. And for iron study, her serum iron and ferritin are reduced. Her liver function test is below normal range, and her serum calcium is also slightly low. Next. And the plan is to do OGDS to rule out dislodged stent. So that's the diagnosis. Okay, so for nutritional screening, using the 2002 SPEN, the one that we use basically. So for this, the initial screening, if the answer of any of these questions are yes, then we can proceed to the next screening. So yeah, she has a BMI less than 20.5, lost weight within the last 3 months and reduced dietary intake within the last week due to loss of appetite. Next. Now for the next step in the nutritional screening, since we don't know what's her loss of weight, we can use the second option, which is BMI 18.5 to 20.5 plus impaired general condition. So her score here is 2 on the left hand side. On the right hand side, she does not have any of these significant conditions. So far her score is 2, but if the patient is 70 years old, then you can add 1 to the total score. So that makes her 3 actually. Next. So she should initiate a nutritional care plan. And speaking of nutritional care plan, this is pretty much the same as presented by the previous presenter. So next, start off with the total calorie requirement. Since she's not critically ill, and her
So,
BMI is
root untuk patient ni,
sorry,
root.
root
Yes, the root of nutrition. Antara
parenteral.
Ah, kenapa parenteral pula?
Because she cannot tolerate liquid diet or soft diet, and they haven't done an OGDS to put in any enteral feed.
Jawapannya enteral lah. Buatlah GDS, boleh masukkan rasio.
Belum lagi buat OGDS sebenarnya.
Belum lagi. Okey
Belum
lah.
lagi. Sebab
So
dia
dia
nak
sementara nak OGDS plus rasio.
for the Rouse tube, I'm not sure if their plan was to put Rouse tube, but they were gonna do OGDS to rule out dislodged stent lah in this patient.
Okay,
Yeah.
ni patient mana ni? HD?
Suspect.
Suspect. Patient mana ni?
GS2, Rakia.
Rakia?
Rakia. This is like the first of May lah. The
Rakia?
first of Sorry?
Sebab tadi round tadi tak ada pun.
Tak, ni patient. Dah sebulan lepas dah.
Lah, dah sebulan depan. Okay.
Yeah.
So, ni discharge.
Yeah, she's not in the ward anymore.
Okay. Discharge dengan nutrition care apa dengan nutrition 3 dengan era 3.
Yang tu tak sure saya. I didn't follow until finish lah.
Tak, patient ni kalau nak discharge lagi lah tak boleh parenteral. Mana nak dapat parenteral machine dekat rumah?
Tak. Itu
Enteral lah. Bukan enteral. Bukan sure punya. Dah insert rice tube apa sama ada buat GTS rice tube ataupun stenting. Kau cuma nak makan macam ni. Okay, continue.
Okay. So for her total calorie requirement, same formula as previously, 25 to 30 kilocal per kg, and if we calculate that, we would get 1000 to 1200 kilocal per day. And since our target is 80%, then that would make it 800 to 960 kilocal per day. Next. Okay. So for total carbohydrate requirement, we can use 2 to 5 gram per kg per day. And for this case, I'm going to use 2 gram per kilogram, 2 gram carbohydrate per kilogram body weight per day. And we will get 80 gram carbohydrate per day and 320 kilocal carbohydrate per day. And for fat, I will do the same, but I will use 0.75 gram fat per kilogram body weight per day. And that would give us 252 kilocal per day. And since we use the normal ratio of 70 to 30, with our current carbohydrate and fat kilocalorie, we'll only get a ratio of 56 to 44. So if we adjust 70 to 30, then we would get 400. Ideally, we get 400.4 kilocal carbohydrate per day and 171 kilocal fat. per day. Next. For total protein requirement, we can use 1.2 to 1.5. In this case, I'm going to use 1.2. And that would give us 48 gram protein per day. And that would give us 196 kilocal protein per day. And for nitrogen requirement, since our protein is 48 grams, that would give us 7.68 gram of nitrogen per day. However, since we have to adjust the nitrogen to non-protein calorie to the ratio of 1 to 150, then after adjusting, that would give us 3.86 gram of nitrogen per day. Next. This is for fluid requirement. Just a simple calculation. She would need 1 liter to 1.2 liters of fluid a day. Next. Okay, so in theory, our carbohydrate per day would be 100.1, fat 19.06, protein 48 gram per day, and nitrogen 33.86. Using the formulas lah. For carbohydrate, I use 2 grams, fat 0.7, protein 1.2. And that's in theory, but in reality, the numbers are a bit different. For example, glucose would give us 85 grams instead of 100.1, fat 34 grams instead of 19.6. And I think this is due to the formulation lah. This is a formulation use. This is a SMOF Cabevan. Yeah. So next. Okay, so just a bit of a discussion. Parenteral nutrition is intravenous administration of nutrition, which includes protein, carbohydrate, fat, minerals, all your essential vitamins for patients who cannot eat or absorb enough food through tube feeding or formula by mouth to maintain good nutritional status. Next. There are some indications for parenteral nutrition, but generally when enteral feeding is not possible.
Benda ni. So ni kita panggil apa? So, kalau patient ada intestinal failure.
Oh, okay.
Kalau patient ada.
Okay.
Example? Ada example tak sini?
I think I do ada at the end.
Apa? Give me one.
Basically, okay, tak ada.
Example senang, short bowel syndrome. Kalau patient tu short bowel syndrome, ataupun patient ada enterocutaneous fistula. Okay. Ataupun ada case selalunya patient dekat ICU lah. Patient hemodynamically unstable in severe sepsis. Patient ada prolonged ileus Takkan kita tak bagi dia takkan tak bagi dia nutrition langsung. Dia ileus dia berminggu-minggu. So kita kena kasih parenteral nutrition. Okay, if the gut functioning, okay, use the gut. Okay, kalau ada dysphagia, ada due to tumor, kita try to bypass the tumor ataupun kita try to put stent to open the lumen. Kalau patient ada gastric outlet obstruction ke due to CA advance ke, ada option lagi. Kita boleh buat enterocutaneous tube feeding. Kan banyak option. Selagi gut tu functioning, try to use the gut. Bila tak functioning, kita use them. Okay, kita continue.
Okay, next. Okay, oh wait, no, I actually do have intestinal failure example. Okay, so there are a couple of indications. For example, impaired absorption, short bowel syndrome, mechanical obstruction. Yeah, I think these are already mentioned.
Ni tak baca slide lah ni. Tak baca slide lah pasal lo nak present ni. Okay, apa?
Dah lama. Okay, next. So here are a couple of examples of parenteral nutrition. parenteral nutrition can come in peripheral or central line. So here are some formulations. Carbivan, smofcarbivan can be used for peripheral, and there's also another formulation for central peripheral nutrition. Okay, next. Okay, and since this patient is using smofcarbivan, she's using the 1206 formulation. And just from this diagram, I just want to show that there are many different formulations for different patients with different requirements. Next. Uh, okay. And here some other indications for parenteral nutrition. You can give pre-operative parenteral nutrition. I've read it somewhere in the Aspen guidelines, or post-operative parenteral nutrition, uh, which is essential lah, because if the post-operative patient is malnourished, then that would affect your wound healing, your immune function, your muscle function, and that would lead to more complications. Next. Okay, and there are two types of parenteral nutrition I've put here. One is total parenteral, and second is peripheral parenteral. Total meaning that it uses a central line lah. And in this patient, she's using a peripheral parenteral nutrition. So compared to total parenteral nutrition, um, since the nutrition is being administered peripherally, the max osmolality is usually at 9 milliosmoles. It cannot go any higher than that. So what happens when there is you have to obey this 900 milliosmol per liter max? That would result in your solution, your nutritional solution, having less calories and less reduced dextrose and protein. So what happens when you have reduced dextrose and protein? You have to depend on lipid as a greater proportion of energy. And also it has some constraints on the electrolytes you can give. Yeah, and peripheral nutrition is usually short term. Next. Okay, and there are many ways you can administer for not many, like there's only two I've labeled here, but one is continuous, which is 24 hours, the whole day for severely ill patients, and cyclical administration, which in the case of my patient, uh, she's administered through cyclical administration, which is 18 hours and 6 hours of hands-free period. However, if the side effects, not a side effect, a possible complication of the cyclical administration is the possibility of hyperglycemia and electrolyte imbalance. But you get some period of freedom. Okay, I think that's all from my part. Okay, I'm just kidding. There are these are some of the side effects you can get from total parenteral nutrition. Usually the most common one is increase in body temperature. Yeah. Next. Okay, and there are other complications of parenteral nutrition which can occur at any stage, infection in general, because you're using an IV line. It could be in the placement where there might be a injury, unprecedented injury. There could be a metabolic side effects, hyperglycemia, hepatosteatosis, refeeding syndrome, which the next presenter will be talking about, and intestinal atrophy, since if you're on TPN, then you're not really using the gut, then it will result in the failure due to atrophy. Next. Okay, that's all from my part.
Okay, I'll continue with refeeding syndrome. So What is refeeding syndrome? Refeeding syndrome is a shift in fluids and electrolytes that may occur in a patient who are malnourished after receiving nutritional therapy, either oral, enteral, or parenteral. But this refeeding syndrome are most commonly occur in parenteral nutrition, patients who are receiving parenteral nutrition. So what happens in refeeding syndrome is that the primary physiologic problem is the patient will have electrolyte imbalance, which is hypophosphatemia, reduce in phosphate, hypomagnesemia, hypokalemia, reduce in thiamine, fluid and sodium retention, and as well as hypoglycemia. And clinical consequences of this, patient can develop heart and respiratory failure, cardiac arrhythmias, rhabdomyolysis, seizures, coma, and also sudden death. So, breastfeeding syndrome is actually life-threatening. So what is the pathophysiology of breastfeeding syndrome? So there are few causes that cause patient to have malnutrition, such as prolonged starvation, alcoholism, delayed nutritional support, anorexia nervosa, and also massive weight loss in obese patients. So when patient has malnutrition, there will be gluconeogenesis and protein catabolism, in which the blood glucose level and insulin level will be reduced, glucagon will be increased, and there will be a breakdown of fat and protein, and there will be production of ketone. And the electrolytes like potassium, magnesium, phosphate, and thiamine will be used up with no replacement. Uh, with no replacement. And then when we reintroduce the patient with food, refeeding, the patient will, at that time, the carbohydrates will be main source of energy, and there will be increase in insulin secretion because there will be insulin stimulation. So there will be stimulation of anabolic pathway, so that there will be protein synthesis, fat synthesis, and this electrolyte, which is the phosphate, magnesium, potassium, will be taken into the cells. So this will cause reduce in these electrolytes in the blood vessel, so lead to the electrolyte imbalance, hypokalemia, hypomagnesemia, hypophosphatemia, and also thiamine deficiency. So these are from medical
The,
nutrition
the
therapy.
first, uh, the first electrolyte imbalance, which one? Which one you can detect in refeeding syndrome? The first electrolyte
Phosphate,
imbalance visible. Uh,
phosphate, phosphate will be reduced first.
phosphate, betul, phosphate. So if a patient, that's why if a patient you start feeding, then you have to take electrolyte daily, especially kalau patient high risk for refeeding syndrome. Okay, so once phosphate to become initially normal, then become low, then you worry patient have refeeding syndrome. Okay, continue.
So these are from Malaysian nutritional therapy. There are two recommendations that we can do, which the situation A is to prevent refeeding syndrome in patient at high risk of developing this refeeding syndrome, and the second one is what to do if the patient already developed refeeding syndrome. So, situation A, these are the criteria for patients who has high risk of developing refeeding syndrome, which is patients. The first one is when BMI less than 16 kg per meter squared, unintentional weight loss more than 15% within the previous 3 to 6 months, and patient who has very little or no nutrition intake for more than 10 days, and also low level of potassium, phosphate, and magnesium prior to any feeding. The second one is if the patient has two or more of the followings, which is when BMI is less than 18.5 kg per meter squared, patient has unintentional weight loss of more than 10% within previous 3 to 6 months, and patient has very little or no intake for 5 days, and history of alcohol abuse or drug use, or some drugs including insulin, chemotherapy, antacids, and diuretics. So if patient has this high risk of developing refeeding syndrome, the approach is to do gradual introduction and advancements of nutritional therapy, which is the first one. We need to identify the patient who has high risk, and if the patient has this risk, we need to trace the serum potassium, calcium, phosphate, and magnesium level every day. And before initiation and during the first days of nutritional support, we need to provide oral thiamine 200 to 300 milligram daily, vitamin B complex, one or two tablets 3 times daily, or full days daily intravenous of vitamin B preparation if necessary, and also balanced multivitamin. And we need to trace the element supplement once daily, and we can give maximum of 10 kilocalorie per kg per day, which is when we want to introduce the nutrition, we need to give maximum of 10 kilocalories per kg per day and increase slowly to achieve the requirements by 4 to 7 days. And we can provide oral, enteral, or intravenous supplements of potassium, phosphate, and also magnesium. And also, of course, we need to monitor the serum potassium, calcium, phosphate, and magnesium, as well as fluid balance and cardiac status to assess the refeeding syndrome, either the patient developed refeeding syndrome or not. So the next one is what to do if patient has already developed refeeding syndrome. So the criteria of confirmation of refeeding syndrome is when the electrolyte severely low electrolyte concentration, when the potassium is less than 2.5 micro millimole per liter, phosphate less than 0.32, and magnesium less than 0.5. Also, if the patient has peripheral edema or acute circulatory fluid overload, and disturbance to organ failure includes the respiratory failure, cardiac failure, and also pulmonary edema. So what to do is the approach is evidence-based calorie restriction protocol as the therapeutic option. So first we need to confirm the patient has refeeding syndrome after initiation of nutrition, and then what we need to do is reduce the current nutrition support to 20 kilocalorie per hour for 2 days, 48 hours, and replace the phosphate deficit. And we can administer daily 100 milligram of IV thiamine and other B group vitamins and balanced multivitamin, and trace the element supplement as clinically appropriate. And also we need to do frequent monitoring and supplementation of electrolytes that are low, such as potassium, magnesium, and phosphate. And then we need to check the serum phosphate. If it is if it is less than 0.71, and then we need to repeat the second step back. If it is more than 0.71, we can increase the nutrition support to from 20 to 40 kilocalorie per hour for the next 24 hours, and continue the frequent monitoring of phosphate, as well as continue the supplementation of vitamin, and monitor the low electrolytes, and as well as the supplementation. And if the serum phosphate is more than 0.71, and then we can advance the nutrition support from 40 to 60 kilocalorie per hour, or 80% of the goal of the nutrition goal, uh, until the phosphate remains more than 0.71, and then we need to continue the frequent monitoring of phosphate, as well as continue the vitamin supplementation, and monitor the low electrolytes, and monitor also the supplementation of low electrolytes. I think that's all for refeeding syndrome.
Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. So my name is Sawa. I'll be continuing the next part of the presentation, which is the nutrition therapy in the outpatients. Next slide. Okay, so first for the nutrition therapy for the preoperative patient. So preoperatively, we will initially do a screening or assessment by using the NRS to determine whether with this way to determine to classify this patient whether it is at a high risk or at low risk patients, which is in which the route of therapy is different. Okay, so next. Okay, so as mentioned earlier, patients who are preoperatively patients will 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 need to undergo nutrition assessment by using NRS. So to classify whether they are at high risk or low risk, but both will benefit from the nutrition therapy. But the patients with severe nutrition or a high risk nutrition, higher nutritional risk, will have a much more benefits of receiving this nutrition therapy, even if the even if their operation is being delayed due to the reason they are receiving this therapy. So meaning to say that comparing whether they go to operation and receive nutrition therapy first is much better rather than go to surgery, because we do not want to operate in any patients who are unfit, as it can cause uh, poor outcome later on in terms of recovery after.
Better in term
So
of what?
ideally based on the ASPEN guideline. Sorry, Victor?
Better in patient receive
Sorry,
nutrition therapy.
not
Patient receive nutrition therapy before surgery. Better in term of what?
better
Apa yang
in terms of if I'm not mistaken, better in terms of recovery, if I'm not mistaken.
recovery how? Recovery macam mana?
Recovery
Statement tu.
recovery post-operative
Yelah.
recovery.
Macam recovery ni broad spectrum broad segment ni in term of what?
They have a lesser chance of getting surgical site infection. Sorry, a lesser chance of getting surgical site infection. Patient who receive preoperative nutrition therapy, because they are equipped with enough nutrition.
Side infection je kan banyak lagi. So
Sorry?
first patient can prevent post-op complication. SSI one of the complication, anastomotic leak one of the complication, apa lagi? Patient boleh dapat hospital acquired pneumonia one of the complication. So one able to reduce possible post-op complication. Second, promote healing. So patient kalau ada wound dia akan cepat heal.
And shorter hospital stay.
Yeah, betul, shorter hospital stay. Lagi bila dah shorter hospital stay, dia dapat reduce the cost. Yalah, logik lah kan, di hospital sekejap
Yes.
cost pun dapat reduce. Okay, continue.
Okay, so based on the ASPEN guideline, a period of 7 to 14 days might be appropriate for these patients to receive nutrition therapy before going to surgery. Okay, next. Okay, so since we talk about regarding the screening first to classify the patients based on whether they are at low risk or they are at high risk. So we talk about the patients who are at the low risk group first. So patients who are at low risk group or have an NRS of score of less than 5. So we will start comments on the oral nutrition therapy for 7 to 14 days, and then we start to reassess. Then we reassess at daily basis with according to their albumin level. If they are according to their albumin level, if the energy needs are met by normal feeding, uh, or by uh, normal diet. So if, so we try to assess whether the energy is met by or not by normal feeding or normal diet. If not, then we need to reassess back with if the patient need to reassess back regarding the patient's risk scoring using the NRS. If it's came back as less than 3, so we need to start the patient with oral nutrition supplement. If
Yang ni
the
skip.
patient score at 3 to 5, then we need to start at
Yang ni skip. Yang ni
oral
skip.
nutrition supplement.
Yang ni skip. Yang
Sorry,
ni skip. Yang ni skip. Tak.
okay, okay,
Supervised.
okay. For the
Ni pun skip.
sorry,
Okay. Okay. Continue.
sorry, Mr. Tak, not clear.
Ya ke?
Okay.
Tak clear ni.
Okay, so hello, sorry, Mr.
Continue.
Okay, okay. Okay, so when does the oral nutrition supplement is preferred? So oral nutrition supplement we offer to patients when the patients do not meet their their energy needs from their normal food or daily diet alone.
Ni pun
So
skip.
and we also give
Ni pun skip.
the oral
Kan dah
nutrition
belajar.
supplement. Skip juga. Okay.
Skip. Parenteral, enteral semua kan dah
Okay.
belajar. Post-qualification. Okay.
Kira dah tak ada. Okay, so that's all.
Okay, Assalamualaikum. I will continue with the last topic, which is post-operative nutrition. But then I think most of the things has already been mentioned somewhat by the previous presenter. Okay, next slide. So post-operatively, in general, oral nutrition intake should be continued without interruption after surgery, which is we can initiate fluid intake within hours after surgery. But then in some cases, oral intake is usually delayed because due to swelling, obstruction, or impact gastric emptying. So some patients, they need early tube feeding. So the indication is when the early oral nutrition cannot be started and the oral intake is inadequate, less than 50% for more than 7 days. So the indication is for these three. For example, in patients undergoing head and neck or GI surgery for cancer, they need early post-operative enteral nutrition because this patient often shows nutritional depletion before surgery, and therefore there has a higher risk of developing septic complications. So any complications can delay oral and enteral feeding. And then patients with obvious malnutrition at the time of surgery, as well as patients with severe trauma, including brain injury, because they tend to be malnourished and undernutrition. So we need to start them with enteral nutrition. Next slide. So when to start early enteral nutrition is within 24 hours after surgery if indicated. So what to give is standard whole protein formula. Homemade diet is generally not recommended because it can lead to tube clotting and risk of infection. But if the diet is made only for that one patient and not for the whole ward, then the risk of contamination is lower. So how this has already been explained using the nasovaginal needle catheter jejujestomy and long-term nutrition. The next slide.
So ni nak insert ni semua ke ni?
No, depends on the condition of the patient.
For top apa? Apa dia punya statement dia?
The statement.
Yeah, if patient expected unable to take orally within 7 to 10 days, kalau tak salah saya, 7 ataupun 10 days, within 7 to 10 days, and then nutrition therapy is indicated.
Okay.
Kalau patient tu boleh makan macam biasa, takkanlah kita nak sumbat nasogenous tube feeding apa tu semua. Lepas tu, if patient unable to take at least 50% of the enteral nutrition, enteral feeding is indicated.
Okay.
So kalau dia dapat at least 50% tu pun dah cukup dah.
Okay, so so do we continue enteral nutrition after discharge? It depends if the patient develop complication, complication, because they tend to lose weight and are at risk of further deterioration. So, for example,
After discharge?
Sorry, doctor.
After discharge apa? Discharge ke rumah?
Yes.
Okay. So soalan, can you do enteral nutrition? Can you do nutrition therapy kat rumah? Yelah kan, cakap nak discharge dengan enteral ni kan. So can you do enteral therapy kat rumah?
Enteral, I think can.
Ha? Can ke cannot? Jawapannya boleh. Boleh. Okay, tapi kita kena monitor dulu few days. Dekat ward, patient can follow or not our instruction. Dia tahu apa kita kena give education to the patient. Boleh? Tak? Yalah. Kalau nak sampai patient dapat normal BMI tu berbulan. Yalah, mana ada orang naik badan normal tu set. Okay, we can give nutrition therapy dekat rumah. Okay, but kita kena properly educate the patient. Dengan apa, or kita properly educate the family members. Okay, once they understand everything, baru kita boleh allow. Kalau tak, then tak boleh. Okay, continue.
Okay. So patients like undergoing major GI or major GI surgery, then we can consider giving enteral after discharge. Okay, next slide. This is for parenteral, considered only in patients who cannot be adequately fed enterally for at least 7 days. For example, in intestinal dysfunction, especially in the early post-operative phase. So we can administer parenteral nutrition as soon as possible if enteral nutrition is indicated. Next slide.
Ada pun 7 days. Okay. 7 7. Saya ingatkan lupa 7, 10 days. So 7 days. Okay, continue.
Okay. Next. So this is just the flow scheme of post-operative nutrition. So if the patient oral intake cannot be realized for 5 days or less than 50% for 7 days, then they are indicated for nutrition therapy. Next slide. So nutrition therapy, we can consider first enteral nutrition if not contraindicated. But then if 7 days, in 7 days, less than 50%, then we can consider supplemental parenteral nutrition. And then apart from giving the parent nutrition therapy.
Di mana nak nampak? Ni yang kecil sangat. Okay. Tak apalah. Next time if you present, kena zoom lah kalau tu sangat kecil ni. Kecil sangat. Okay, continue.
Okay, so apart from giving the nutrition, we need to give dietary counselling as well for the patient to
for the patient to be compliant as well. Okay. Next slide. This is according to the ASPEN guideline in patients undergoing transplantation like heart, lung, liver transplantation, then they can.
Tak apa, yang ni sikit-sikit. Yelah, special case ni apa semua, manual ingat sikit-sikit.
Okay. I think that's all for the post-operative nutrition.
Oh, habis dah? Habis dah?
Dah.
Okay dah. So, any question? Ada apa-apa soalan ni? Ada apa nak tanya soalan? Ada, tak ada? Okay, saya count sampai 3. Kalau tak ada, tak ada lah. Okay, 1, 2, 3. Okay, tak ada. Okay, so apa nutrition therapy ni very unlikely untuk keluar OSCE. very unlikely untuk keluar OSCE, tapi dia akan keluar MCQ ataupun OBA lah. Long case, short case lagilah tak ada kan. Kecuali kalau kita tanya how you assess clinically, how you assess the patient nutrition. Okay, so kalau tak ada kita boleh close lah. So semua pun boleh sambung study ataupun tidur, minggu depan nak exam dah kan. Okay, so good luck for exam. Okay, so kita jumpa lagi esok. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr.
Okay.